couple of minutes and then officially start. Going on, each presenter will have 7 minutes to talk. Following this, we will have 3 minutes of question and answer. We will begin with the first presenter, that is, can you go to the next slide? Yeah. Nuzulu. She is from Health Policy and Administration Department, Indonesia, and she will be speaking on barriers to gender mainstreaming in health programs in Indonesia. So over to you, Nuzulu. Please begin your presentation. Uh, Nuzulu, have you been? I am not able to see her in the list. Uh,
He might not be in currently. So do you want to move on to the next presenter?
yes, we can go on with the next presenter, that is Shivani Savtagi. Yeah, yes. Uh, Over to you, Shivani.
Thank you, Ketki. Thank you and good morning to everyone. Yeah, myself Sivanand. I will be presenting on development of self-reliance framework for primary healthcare using traditional medicine intervention, a case study in 2 southern states of India. Next slide, please. Yeah. So when you look at the context of India, so we have multiple approaches to healthcare. It starts from denial to care, spiritual healing, lifestyle medicine, modern medicine, and also traditional medicine, which has 2 components of codified system of medicine and also non-codified system of medicine, which is originated from intergenerational knowledge from families. And this amalgamation of various practices can be called in one component called as a self-care. And in the various documents, the self-reliance right from the Alma-Ata Declaration, there has been a connotation which is used called as a self-reliance, which talks about empowerment of people, informed healthcare choices, and responsible health and lifestyle practices. While there are already complex healthcare practices embedded in the communities and the families, why are we talking in the context in the today's context about this self-reliance is a question. Now, next. So when you look at the SDG 3 goal, health and well-being has been set as a goal by the year 2030. In order to achieve this goal, it's important that we all, and it is important to place the health of the people in their hands by making them self-reliant. Also, next. Also, there is the increased voice towards creating a person-centered care that also calls for recognizing the strengths and the abilities of people to enable for independent and fulfilling life. Next. So in the context of low and middle income countries, majority of the families, more than 70%, rely on traditional medicine usage for the primary healthcare conditions or for treating the common ailment, which is a predominant source for primary healthcare. And this, due to its cultural relevance and also use of local resources, the use of traditional medicine facilitates self-reliance in primary healthcare. However, this self-reliance is a very broad and complex term, which we revealed in the one of the review paper that we wrote as part of this work. And because of the complex nature, we also recommended that there is a need to have an empirical study that aims to develop a self-reliance framework, which aims to delineate various factors that can be focused on designing intervention that can enable self-reliance in primary health care, and that further enhances creating a person-centered care, and which ultimately may have might contribute to health and well-being, which is the SDG goal number 3. So this study focused on creating a self-reliance framework in the context of self-reliance in primary health care. Next. So we adopted three important steps to create the self-reliance framework. The first one is scoping review, which came out with the conceptual framework. And the second and the third step is the case study research and the participatory research. I'm going to focus on the step 2 and the step 3 process in this presentation. Next. Next. We adopted a multiple case study method. The multiple case study method allows an in-depth and multifaceted understanding of a complex issue in real-life context. Since self-reliance is embedded within the experiences of the people, it is important that we hear from them, and that's why this multiple case study method was adopted. To do that, next. To do that, we selected purposefully two traditional medicine intervention from an organization called as the University of Transdisciplinary Health Sciences and Technology in India, which has extensively worked on traditional medicine in HD Kote in Mysore district in Karnataka, which is at the household level traditional medicine intervention, and in Kerala in community level traditional medicine intervention. With a purpose sampling approach in both the case study, we selected 30 in-depth interviews and 3 focus group discussion in household level traditional medicine intervention. And in community level intervention, we conducted 22 in-depth interviews and observation. And using this data, we went on doing the thematic analysis to refine the framework which was emerged from the scoping review. And as a result of the case study approach, we got the second version of the self-reliance framework, which focused on understanding what are the factors that emerges in the emergence of self-reliance. In the next step, we went on introducing this framework to NGOs and traditional medicine practitioners who can look into and help us to further refine the framework so that it can be adaptable at the community level. And through the participatory approaches, we synthesize the third version of the framework, and which is the final version of our self-reliance framework. And our framework, next slide. Yeah, so this is the framework that we have come out with the after the iterative process of scoping review, multiple case study method, and then the participatory approach. Basically, we talk about the two components. One is the environmental factor and the individual factor. So although the case studies were focused on the household and the community level, but the actual manifestation of the self-reliance happens at the individual level. If you look at the left side of the part of the framework, where the environment, there are various health system factors and also socio-cultural factors which influence and they traverse through the community, household, and the individual level. However, the individual part has been taken out in the right side and understood the concept how the individual itself have the origination of struggle to establish a health behavior. So once health behavior is sustained, when an individual felt autonomous, related with the environment, and the adequate competencies are developed, and there is a decision-making ability for an individual. An individual feels more self-reliant when it aligns with the environmental expectation. So, however, when there is a mismatch between the individual's beliefs, norms, and the practice with the environmental factors, there is always a conflict. And also, there is a process of re-emergence by adopting awareness, desire to change, learning, and practicing new skills. And this all emergence and the conflict is already happening within the socio-political context. Next. So considering the various factors that interact in the emergence of self-reliance, so we say that self-reliance is not a static, it's a dynamic and context-specific. Hence, we define the self-reliance as an ability of an individual to make informed health decisions, to use available resources, considering social and cultural beliefs to achieve sustainable health behavior through which an individual achieves a state of autonomy, competent and responsible towards his or her health that gives a sense of empowerment to an individual. Such a state of health behavior that is flexible and adaptable to a particular context is termed as self-reliance. Next. So hence, we say that self-reliance is socially constructed, although it is focused on the self, but however, we cannot deny the environmental factor. An informed decision that should be driven by the multi-perspective evidence, because already we cannot rely only on the scientific evidence. There is an experiential knowledge which is embedded within the communities. We need to broaden our approach in the creation of the evidence. And self-reliance, since it is dynamic and context specific, we need to contextualize it in an intersectoral space within the health system. And there is a continuous need for providing health literacy for both care providers and receivers in order to create an enabling environment that could help us to enable self-reliance of families and the communities. So these are the very important philosophical approach that could help in many policy implications. Next slide. For example,
Shivani, to interrupt, you'll have to wrap up in another 1 minute.
okay, thank you. Yeah, please go bullet points. Yeah, there are various policy documents. For instance, Ayushman Bharat program, which is one of the flagship program, which also talks about informed choices in self-care, and self-reliance, if enabled, can contribute to Ayushman Bharat. And also this people-centered approach and WHO's framework of accountability component, and also the pluralistic health system, which we are talking about, the informed choice of healthcare. So all these, if we are able to enable the self-reliance of the families in the communities, the policy implication can happen drastically if we achieve the self-reliance in primary health care. Yeah, next. I acknowledge the funding support of your Friends of Hope, ICMR, and also other organizations, and Dr. Prashant Innes, John Porter, Hari Nagendra, and Upendra Bhojani for being in part of my study. Thank you.
Thank you, Shivanand, for this engaging presentation on self-reliance. I would now open the floor for question and answer. For all the panelists, if you have any questions, please type in the chat box. For others, you can type in the question and answer tab. In the meantime, when the questions come in, I would like to just ask one question regarding your presentation. You mentioned about the policy implication in the last slide. Can you briefly elaborate on it, on how exactly and immediate policy implications of your research?
Yeah, not an immediate policy implication, Ketki. Actually, Ayushman Bharat program, which I mentioned, has also brought a components of informed choice and also self-care as a part of the Ayushman Bharat program. But however, the program continuously focused on the passive approach and the institutional based approach, where community health officer has to visit the people. The active participation of the people has not been taken into consideration, although again it is depending on the healthcare provider. So in that case, if the principles of the self-reliance is adopted in to enable people and communities to take decision on how to choose, then it makes a huge difference in the policy implication and achieving the goals of the Ayushman Bharat program.
Thank you, Shivana. We have one question from Mahalakshmi. He wants to congratulate you on the wonderful conceptualization. He is asking how was the challenge to explain the concept of self-reliance by the participants of interview overcome?
Yeah, thank you very much, Malaxmi. There was no straightforward answer for defining the self-reliance from the participant. However, the experiences that they were sharing, how they were able to navigate the health system, how they were able to function within the socio-political context, how they were treated when they went to a hospital, or how they were able to identify the solution using local resources when the system has pushed them. So all these different kinds of experiences, the navigation process helped me to understand what self-reliance means. Also, I used a theoretical framework of self-determination theory, which also talks about sustained engagement of a health behavior, why there is a sustained engagement of a health behavior of an individual, why a person shifts from one behavior adoption to another behavior adoption, and how this is dynamic versus how this is contextual. So those are the kind of iterations that I was doing an exercise and came out with an explanation of framework and the definition. But yeah, it was very, very challenging, I could say.
Thank you, Shivanand. And in the interest of time, we would go on to the next presentation. If you have any questions for Shivanand, please type in the chat box and he will respond in the chat box or the question and answer tab. Nice. Moving on to the next presenter, we have Dr. Janni Kaur from Myanmar, who would be speaking on revitalizing ethnic health information system. So over to you, Dr. Zarni.
Thank you so much. So I would like to start by saying that I'm a current migrant right now, and I had to listen the yesterday presentations and yesterday talk via a mobile phone because I have to go to an immigration office yesterday. So I can now say that I have lived experience. I spent like the whole day as a migrant trying to apply for a visa in a third country. So it's kind of like an humbling experience, but at the same time, I can now say that I have lived experience. I can share. I'm working in the field of health informatics, but I would like to share one of the research that I'm leading. So that's the revitalization of ethnic health information system in conflict affected area. This is the content outline. I'm not going to go through each and every list, but please, next, please. So the background is that health information systems are essential, and especially in the conflict affected Southeast Myanmar and health system in those areas, we face a lot of significant challenges. Example like armed conflict, limited resources, cultural and linguistic barrier, and there is a need for research to explore the potential strategies and revitalizing and how to strengthen them. Next, please. So the rationale for my research is that ethnic minority communities, they develop their own health system, but because there are a number of ethnic communities, it becomes fragmented. And since it is not a single leadership or single governance, it's often under-resourced. And there is a need to examine the current state, even after the military coup, even after the COVID. A lot of the system has to be changed. A lot of the system has to be modified to make sure that some of the system that we are implemented are still up to date and still contextualized. So well, we need to identify the factors that are enable or hindering their function and performance. Next, please. So the primary research question for this research is that what is the current state of ethnic health information system, EHIS in short, in Southeast Myanmar? Secondary research question is what are the factors influencing the performance? And the second and another question is that what are the barriers and challenges? Are they doing well? Are they doing, and what kind of barrier they faced before? What kind of barriers they are facing right now? And finally, I would like to actually disseminate this research to some of the policymakers, some of the future policymaker even, because currently in Myanmar, we cannot definitely say which government is operating in which area. So I would like to disseminate this kind of research so that they can use this as a learning tool to actually implement their own health system in the future. Next, please. So the methodology of the research is that we've done literature review using hotfit framework. One of our research gap in ethnic health information system in Southeast Myanmar is that there is zero research conducted using a framework and assessed using human, technology, and organization level challenges. So this is a mixed method study. As a mixed method study, I'm also conducting quantitative research from using 43 respondent via SurveyMonkey, and qualitative in-depth interviews to 7 ethnic health leaders. Next, please. So what are the results? Now, I like the rule of 3. So I'm going to present 3 points for every area. So number one is that we need a lot more community engagement, mainly because community engagement is one of the key one of the key challenges that we face in previous iteration of ethnic health information system. We need definitely more resources. Still, there are a lot of donor organizations still going through the central of Myanmar, and current after the military coup, a lot of the money is not flowing back to the ethnic areas. So we need to make sure some of the resources are flowing directly into the much needed areas like the Thai-Myanmar border area, China-Myanmar border area. And improving, we need to improve the data collection. Current data collection, a lot of the data collection are still done on paper, and we have to digitize using human resources, which is very inefficient, and at the same time, it is not scalable. So we need to improve that. I would like to go to the next slide, please. So in each section, I'm going to still go through what is it and how can we do that. So number one is community needs to be involved in design, implementation, and monitoring. So how do we do that? Active engagement with the community. I really like the last yesterday presentation about nothing about us without us. So if we are studying ethnic health information system, we need to involve the communities and actively engage with them to make sure that they can build local capacity for the sustainability purpose as well, and developing translated data collection to and reports. For far too long, a lot of that tools that we have developed is in English or is in Burmese. It doesn't mean that in the ethnic diverse areas, we can use it as a main solution. So it has to be a translated data collection too. In conflict-affected setting, and the importance of integrating traditional practices. A lot of the presenter yesterday, a lot of the presenter even today already echo this point. So I'm not going to do it again, but it is needed to understand the cultural and contextual behavior in the conflict-affected setting of Southeast Myanmar. Next, please. So resources, conflict area, as I said before, it is very well under-resourced. So how can we change that? Conflict-affected region often lack basic infrastructure like electricity, internet connectivity. We are trying to circumvent those limitations by using even Starlink satellite and solar power, but it's not widespread and it's not at the scale that we want. So we need more resources to deploy such systems. Ethnic EHIS in conflict-affected zone rely heavily on donor funding. Still, according to our latest estimate, we are still short of 75% of funding. And according to the UN, there are 2.7 million migrants population, including myself right now in Thailand. So in that case, we still need to advocate to a lot of their development partners to direct their funding towards where it is needed, and not through the central military leadership. And conflict zone often experience shortage in qualified health personnel, including those trained in managing and utilizing ethnic health information system. There are several initiatives going on currently. Most of them are led by a foreigner. What happened is that that foreigner comes in, they implement one system, and there is no capacity building to the local people. So when that foreigner leave, that system is become unusable, or it is not well maintained. It is not what we want in those areas. And we need to train personnel in data security protocols as well. There are some data breaches in previous years. We don't want that to happen in the future. So those are some of the resources that we need. Next, please. Improving the data collection. How can we do that? Stronger at the EHIS relies on better data. Precise data gathering and management is needed. Currently, as I said before, everything is done on paper. We need to digitize those paper into a digital format using data entry clocks, so it is not sustainable. We need stronger and better data and a lot more technology. And one standard for health data. As I said before, people, ethnic groups in Shan, which is in the eastern border, conduct their own system. Border people in Karen and Karani do their own system. So we need to have one standard so that in the future data can be exchanged and data-driven decision for healthier future. Meaning that right now, only some of the data being collected are used for policy purposes. So we want to change and flip that on its head. So those are the three key points I would like to share about the improving the data collection. Next, please.
Sorry to interrupt you, Remy. Just wrap up in 1 minute.
This is the conclusion slide. So this will be the last slide. Thank you. So collaboration, we need better collaboration. In conclusion, I would like to share that we need better collaboration between ethnic groups, agency, and development partners. As I said before, according to the previous slides, flexibility. System needs to be flexible. Currently, Myanmar is undergoing a lot of transition. We cannot say that this system is the best and push the same. So we need to be flexible in that regard. Innovation, as I said before, we are using Starlink and we are using solar power, but it needs to be scaled up. At the same time, there are several solutions coming online right now, like single board computing, edge computing. We need to leverage those kind of innovative solutions to make sure it is contextualized for the ethnic communities living in conflict-affected areas. So that would be my presentation, and thank you all for your attention.
Thank you, Dr. Zalmi, for this presentation. Slides were really great. I open the floor for question answer. There are two Q&A, and I'll just ask you accordingly. We can. So the first question is: does Myanmar have a central HIS system? If so, does it capture the utilization data of different minority groups? And the same participant is also asking, rather than having different EHIs, would that be worth to have an inclusive central data which can capture these groups?
Thank you. Thank you so much. Those are very interesting questions. So I would like to share that. First, in 2016, to preface that, Myanmar is a part of a network called Asia eHealth Information Network, which is a subset of the WHO digital health literacy program, digital health program in the world. So part of AHIN, we actually hosted in 2016 the 6th general meeting for AHIN. I was part of the team at that time through my national health plan involvement. So during that time, that's pre-coup and pre-COVID. During that time, we started adopting DHIS2 as a national platform. But Myanmar has a long-standing conflict and trust issues. So ethnic organization in the conflict-affected area, they are not fully on board or they want to implement DHIS2 nationwide. It doesn't mean that. So what we did is that as an NGO, I'm working for an NGO called Community Partners International. We are trying to bridge the gap between the central government and the ethnic groups at that time. That's pre-coup. I have to say that. So we are trying to make sure that the data collected, whatever system, can be translated. For example, we need to share malaria data. We are still on track for malaria elimination at that time. So to make sure that those data are collected and can be transmitted to a central DHIS2 data collection database, we need data translator. We are actually implementing, and we have some success in some case, but that all of that stopped after the military coup in 2021, and there's a difficulty in sharing data, especially for the EPI. I'm sad to say there's some outbreaks of very preventable diseases in Myanmar just because that the data sharing and the resource sharing is not there. We are trying to jumpstart that discussion, at least between the ethnic groups in Shan, which is the eastern part of Myanmar, currently in the southeastern part of Myanmar, so that vaccines and some of the drugs needed for deployment can come from the border area, and ethnic groups themselves, they can share data and start thinking from the system perspective. So that's the first question. The second question, what is the role of the small private non-state actor in service provision using technology? I believe it has a big role, just because in Myanmar's history since 1962, we have the first coup, we have the second coup in 1988, the third coup right now in 2021. Because of those long history, there is a long-standing trust issue between the central government and ethnic communities. So, as a employee working in the NGO, but we still see that small private, we can call the whole government as a public setting, where although the ethnic armed groups themselves, they think themselves as a public group, but still operate on a private kind of like organization basic. In that essence, those small private groups have potential to unify the system across different ethnic groups, meaning that we are currently playing a role of integrator, making sure whatever back-end database they use, they are using ICD-10 coding so that the data can be shared without that much need for a human intervention, or maybe even in the future we start to experiment with AI and try to use AI to actually, for example, if you write heart diseases, AI can we are using clinical decision management system. AI can ask like, what is the AI can ask a follow-up question. What exactly is that heart disease? Is it A001 this code or not? So that when people enter data directly into the database, it is already being standardized, and we can play that role, because I still firmly believe that small teams can be much more innovative than a bigger picture. So that's my answer to how that small private organization can play a big role. And the third question, how is that EHIS different from the regular HIS? EHIS, as I said before, we are not using the HIS2. We are using various data collection methods. Some are using Comcare. Comcare is still a subscription-based model, so we need to pay. And some are using open source data collection tools, so it is very different. But at the same time, as I said before, we are trying to make sure every data recorded is in the some sort of standards. And with persisting challenge and establishing the strengthening HIS, how do we see the policymaker being convinced as separate? So policymaker, as I said, they are very diverse as Myanmar right now. So convincing one policymaker won't make a chance. So would make a dent in the big scheme of things. So what we have to do, and what we are currently doing, is we are talking to several leaders. But I also would like to highlight that there is a big coalition of ethnic groups in the border area right now. It doesn't mean that I have to go talk and separate to each other and come up with a different solution for everyone. That coalition exists, and we are talking to every member of the coalition to make sure that when we are implementing a health information system, at least it can be the information can be exchanged in the future. And we are always trying to advocate to the ethnic leaders themselves that they need to think a bigger picture. They need to think from the system perspective, and not only just for immediate needs. So those will be my answer. I'm sure that
Dr.
I can still dive into a lot deeper. But being cognizant of the time, let me stop there. Thank you.
Dr. Zali, thank you for answering this question. There are a couple of more questions for you in the Q&A, which you can type your answer in the chat box. We'll just take one final question from our panelist, Iman. She is asking about while we believe we have to standardize data collection, how do we stay true to being community center in the ways we see and understand, yet build shareable data that is standardized?
Data to
And if you could
standardize.
just keep, your answers short and reply her in the chat box, then we would be on time. Thank you.
Thank you. Just to keep it short, to standardize, it is still a big issue. I'm not saying that it will be done tomorrow. It is an ongoing process. To standardize, we need to talk with every ethnic leaders, and we are still doing that. We are not there yet. Part of this research is to highlight the fact that there is a diverse need, and we are trying to fill that need by talking to everyone. Thank you.
Thanks. So please reply to the question in the Q&A by typing your answers over there. So moving on to the next presentation, I would like to invite Riska for her presentation. Uh,
Hello.
yeah, over to you, Riska.
Okay, thank you, Ketki. Hello, everyone. My name is Rizka Yusiani. I'm from Indonesia. I currently a PhD student of Public Health, Faculty of Medicine, Universitas 11 Maret, Indonesia. Today, I want to present my research about HIV disadvantaged individual. Can we identify causes prevalent gender inequalities in use of HIV services among severely disadvantaged individuals? Next. In this presentation, we have four parts. The first part, I want to tell about the background and methods, results, and also discussion or conclusion. Next. Access to regular primary healthcare is essential for enhanced HIV treatment outcomes. Despite the benefits, a substantial portion of Indonesia's HIV/AIDS population lacks consistent healthcare. Marginalized individuals face barriers like racial or ethnic status, economic challenges, substance use, housing instability, and difficulty establishing relationship with care providers. Women constituting a growing risk group experience insufficient attention, reflecting potential disparities in HIV primary care utilization. Next. Now I want to tell about the research purpose on gender disparities. This study investigates gender-related healthcare disparities among severely marginalized HIV-infected individuals in Yogyakarta City, examining factors such as education, insurance, housing, drug use, and patient attitudes. Next. Between November 1, 2022 and October 7, 2023, we studied HIV-infected individuals in Yogyakarta City, Indonesia, residing in 14 single-room occupancy hotels, commonly used as emergency housing for homeless individuals with HIV/AIDS. Of the 614 individuals encountered, 536 participated, forming a final sample of 400 after exclusions. Inclusion criteria involve residing in target SRO hotels, being HIV infected, including self-reported and medically confirmed. It's higher than 18 years old and proficiency in Indonesia or Japanese. Exclusion criteria included intoxication during recruitment. Challenges such as ineligibility, withdrawals, and data unavailability were encountered, leading to a comprehensive data set that exclude 26 transgender individuals and 18 with missing outcome data, providing insights into the marginalized HIV-infected population in Yogyakarta City. Next. The study involved through procedures where interviewers over 3 days invited residents from single-room occupancy hotels in Yogyakarta City, Indonesia. Utilizing audio computer assist self-interviewing technology, interviews were conducted in Bahasa Indonesia with translated instruments ensuring fidelity. Participants reported on socio-demographic HIV health status and services use. Measures gauging attitudes toward healthcare included access perceptions, mistrust, trust in providers, engagement, and perception of control. A comprehensive medical record review of the last 6 months included ambulatory care data extraction by physicians. The study showed a detailed of understanding of HIV-infected individual in hotels, examining living situations, substance use attitudes, and medical histories. The meticulous methodology aimed to capture a comprehensive profile of participants' health-related experiences in this vulnerable population. Next. The study employed a comprehensive approach utilizing bivariate analysis to compare of HIV-related healthcare patterns between women and men. Outcome variables included primary HIV care services, emergency department visits, and hospitalization. Optimal healthcare was defined by having at least 2 primary care visits in 6 months. Logistic regression models adjusting for demographic and illness severity factors tested hypotheses about gender differences. Socioeconomic and behavioral factors were explored as potential influencers, followed by an examination of attitudes toward healthcare. Missing data were addressed through imputation methods. The finding underscore complex interaction between gender, socioeconomic factors, and attitudes, emphasizing the need for targeted intervention, especially for severely impoverished women accessing HIV healthcare. Next. For the results and discussion, the table 1, consistent with our hypothesis, women exhibited lower utilization of HIV primary care services among 40.6% versus 54.3%, p-value under 0.05, higher rates of emergency department visits, and a trend towards increased hospitalizations, although the latter did not reach statistical significance. Next. In the result 2, beyond gender factors such as education, insurance status, mistrust in the healthcare system, and trust in healthcare providers were significantly linked to HIV healthcare utilization outcomes at p-value under 0.05. Moreover, having an SRO hotel room in one's name, heroin or non-prescription opioid use, and certain perception of illness control exhibited trends, p-value under 0.20, associated with at least one healthcare utilization variable, conversely, cocaine or crack use perceptions of access to care, and engagement with one's providers show no significant association with the healthcare utilization outcomes. And the next slides, we also have result 3, regression analysis aimed at explaining gender differences in HIV primary care. Emergency department visits and hospitalization found that selected socioeconomic, behavioral, and attitude factors did not substantially alter the initial odds ratio associated with female versus male gender. Despite association with some variables, none of the hypothesis measures explain gender disparities in the 3 healthcare service utilization outcomes. The initial odds ratio for female gender remained relatively unchanged ever when all variables were included in a single model. And the study, in the next slide, the study limitation is a knowledge limitation, including potential explored construct related to barriers in HIV healthcare utilization. The volunteer-based convenience sample, while large and diverse, may not be fully representative of the broader population of disadvantaged HIV-infected individuals in Yogyakarta City or the wider in Indonesia. And the implication of study, in the next slide, despite limitation, our study significantly contributes to understanding HIV healthcare disparities. And emphasizes that severely disadvantaged HIV-infected women are less likely to receive optimal care than men. Key factors such as education, insurance, stable living condition, and perceived control over treatment differ between genders and may influence intervention success. Additionally, attitudes toward the healthcare system and providers play a crucial role, suggesting the need for theory-based strategies to address gender and healthcare disparities effectively. So the conclusion of this study explored gender-related disparities in HIV healthcare utilization among severely disadvantaged individuals. Next slide. Women compared to men were significantly less likely to optimally use HIV healthcare services even after adjusting for various factors. Notably, factors including attitudes toward healthcare did not explain the observed gender disparities. The study suggests caregiving responsibilities potentially overlooked in the research, and the profound loss experienced by disadvantaged women may contribute to their challenges in prioritizing personal health. The study highlights the need for qualitative research to delve deeper into understanding how caregiving responsibilities impact HIV-infected women's healthcare utilization. Thank you so much. This is the end of the presentation. If you have any question, please feel free to ask. Thank you.
Thank you, Rishka, for this engaging presentation. I open the floor for question and answer. There is one question. May I know what is the dropout rate, non-response in the study in HIV infection rates? Rishka, would you like to
Okay.
answer that?
Yeah, thank you so much for the wonderful question. In this study, what is the dropout rate and non-response in the study infection rates? Is about the because the population, the samples is not follow the all intervention, and also the dropout is about the people in the sample of the research is not including of the all intervention like the HIV treatment, and also drop out about misconducted and misunderstanding to inform. So we not including all participation in from the since the beginning until the end. So because of that's why it's missing out, and we not including in this study.
Thank you, Rishka, for answering the question. If there are any other questions, please feel free to type them in the Q&A tab or the chat box.
Yes. Thank you.
Thank you, Rishka, for that. There are no further questions. Sorry, there is one more question. So the study is not clear about the sample size. Can you clarify on the sample size? Rishka, you are on mute. If you prefer writing it over the chat box and answering that question, please feel free to go ahead with that. We move on to our last presentation for today. So in this presentation, Bragmandita, she will be speaking on the implementation study of Little Baby Handbook in Indonesia using mixed method. So over to you, Bragmandita.
Okay, thank you, Ketki. So can I share my slide by myself?
Miguel,
Yes,
would that be okay?
yes, you may.
Yeah.
Yeah, so yeah, are you able to share it now?
Not yet, because I cannot allow to share when the participant is sharing.
Okay, try sharing it now.
Okay, thank you. Yeah, thank you for the opportunity. So my name is Brahmandita. I'm from Yogyakarta, Indonesia. the study about the implementation study of Little Baby Handbook in Indonesia using mixed method study and one of a pilot project. And this study was collaborated from University of Gajah Mada and Ministry of Health and also JICA Indonesia. As we know that low birth weight infant has a various health problems such as the physical problems, growth and developmental delay, also mother-infant bonding problems. And in many Indonesian public health services, we are in a limited health resources. So low birth weight infant were a very problem in our setting. In the Indonesian Ministry of Health collaborated with JICA Indonesia, developed the Little Baby Handbook and implemented in a few health facilities in 3 regencies, so in Java Island and also in Sumatra Island, that to complement the mother's knowledge and health worker practices in giving childcare for little babies. We know that the little babies baby who were born at birth with a body weight below the 2,500 grams, the body length below the 45, and also the baby was born below the 37 gestational of age. And the objective of the study, this mixed method study aimed to characterize the implementation of Little Baby Handbook program using a REAM framework, so reach effectiveness, adoption, implementation, and also maintenance. This is the Little Baby Handbook that established based on this collaboration. And we used the method, mixed method study that conducted in February to July 2023 in a 3 district area. So the 2 districts in Central Java and 1 district in West Sumatra province in Indonesia. In total, we create 18 indicators that covering the REAM domain. And we also conducted this mixed method. So the quantitative study, which enroll mothers, the 266 mothers, and also we enroll 40 workers, and we use the semi-structured questionnaire. In a qualitative study, we also enroll mothers for the focus group discussion, and also 33 health workers for the focus group discussion, and also we enroll the 18 managers from the health facilities to the in-depth interview. We interview mothers and also send online questionnaire to the health worker. We want to capture their knowledge, their perception, and also their practice about the child care, and also the utilization of this book. And the Little Baby Handbook was also distributed to the mother who delivered the baby with a prematurity, so the gestational age below 37, and also the birth weight below 2,050 grams, and also the birth length below 45 centimeters. The 18 indicators of our study covering the REAM framework, this consists of the distribution of the Little Baby Handbook for the reads, and for the effectiveness, we want to know about the little baby knowledge and also perception of the health workers and also mothers. And for the adoption domain, we want to see about the availability of Little Baby Handbook, training, and also the trainers. And for the implementation, Little Baby Handbook practice of the health worker and also mothers as a domain that we want to know, and the maintenance from the REAM framework, we want to look about the value, budgeting, and also workload for the Little Baby Handbook program. And the result from our study was the participant of the study, we divide into 2 based on the type of the study. So the quantitative study, we got 211 for the baseline survey, 166 for the end-line survey, and also for the health workers. And for the qualitative study, we enrolled these 20 mothers, 33 health workers, and also 13 managers of the health facilities. The distribution of this Little Baby Handbook is about 94%. So only 6% from the little baby's mother that not get the little baby handbook. And the knowledge of the health worker, we see that the knowledge of the of the health worker, it was significantly improved in the understanding of little baby handbook criteria, how to correct the age and also the growth and development and child immunization. This is the domain of the knowledge from the health worker that improve. And for the practices of the health worker, we have several questions, and we know that there is a significant improvement of the health worker practices regarding the uses of little baby handbook, and also the frequency of the counseling and providing the information to the mother with little baby is also improving, and also they did it the timely and with the empathic manner. The perception of the health worker, we have several questions about this one. And the perception, when we compare between before and after, or based on an online survey, we see that there is a significant improvement. So the effective communication, the emotional support, and also providing health education that conducted by the health worker was significantly improved. And the knowledge of the mother. So when we see that there is a significant improvement in the knowledge of the health worker, also with the knowledge of the mother, we see the significantly improve that there is increasing in the score of our knowledge questions. About the practice of the mother. So the mother practices about the child care for the little babies. We see that the kangaroo mother care was improved, and also we also looked at the immunization. So child who got the immunization also improved, and the improvement of the mothers about the child care is also can see in some practices. And the perception of the mother. So the mother perception, we ask them several questions. The mother is given information about the timeless of mother and child handbook, and also little baby handbook care for the baby. So this is also improved, and the most significant is improving. Mother can communicate actively and effectively with the health worker. So before the implementation of little baby handbook, there is some problem in the communication. There is some gap between mothers and also health workers. So this book can also bridging communication between mother and health worker. And from the qualitative study, we found enablers and also barriers. So this is in the some domain of the REAM framework also found in the qualitative study. So we saw that the enablers is one of the most motivation of the health worker. So when they get the new implemented program, they still motivated, and with the government support, the leaders and also community is also one of the enablers. And the positive response for the mothers and also the sufficiency of little baby handbook stocks is also founded as the enablers in our study. And the other hand, the barriers, we found that implementation of the little baby handbook, inadequate supervision and monitoring from the district health officer, province health officer, and also from the Ministry of Health. So when we look at it's not some of the implementation, it's not good implemented, the supervision and monitoring is still lacking. And the low education level of the mother is also one of the barriers. And we know that most of our mothers in these three regency also still in a low education level. And the geographical limitation in some area of the pilot study project, that some of this area is still not really achieved from the health worker. So they are living far away, and also they live like very far in the hill, and also in a very far village, very rural area. So it's also quite difficult to catch the mothers with the little babies. And also the other barriers found that no regular training. So the health worker just train in the beginning of the implementation, and there is no regular training for refreshment. This is also the one of the barrier. And the last one is there is no special budget allocation from the little baby for the little baby handbook program, except only for the printing of the book stock. So this is also one of the barrier when they are far from the others. They have to go to the a very rural area, and there is no special budget allocation. So this is the and also barrier that we found in a qualitative study. And we conclude that the Little Baby Handbook program was implemented for 1 year in our country, and this is improved the quality of health services for the little baby's mother, and also promoting the education and emotional support for the mother and families are important, and reducing the disparities and also improving the health equity. And based on the finding of the study, we recommend that when the government want to scale up into the national program, so the regulation from the government needs to be set up first in all province, covering how to monitor supervision, also how for the budgeting, and also the to conducting the training for the trainers, and not only in the beginning but also regular refreshment, and also doing the regular training for the health worker is needed to make the knowledge of the health worker is always updated. So this is our team with the support from the our Ministry of Health and also from JICA Indonesia. So thank you, and for all your attention, opening for the question and answer session. Thank you.
Thank you for your presentation, Deepa. And I've opened the floor for Q&A. We have one question. Great work related to LBW topic from Indonesia. And I do feel, I'm just reading the question from Dr. H.K. Das. I do feel that the position outcome measures coincides with the handbook guidelines, which are a great benefits for HCW in places where medical manpower is inadequate. Great work. The outcome is great, and all the best for the team for coming days. Sorry, this was not the question, but just a comment from Dr. H.K. Das.
Thank you.
If there are any questions, please feel free to type in the Q&A or the chat box for panelists. Uh, there is one question from participant. What plans are there to continue with the LBH program for sustained implementation?
Okay, thank you for the question, nice question. And our Ministry of Health have a plan that want to scaling up the program to all the Indonesian province. And for the some of the recommendation that I already mentioned before, that we try to advocate the Ministry of Health that we have to set up first about the policy, about the how to monitor, how to do supervision, and also set up for the budget allocation for the Little Baby Handbook program, so that we think that it would be better to setting up for all the province, because in Indonesia we have many provinces, and some of the province also have an equity, so we have to adjust for that, and we try to implement in this year for the whole Indonesian. Thank you.
Thank you for answering the question. If there are any questions, please feel free to type in the Q&A or the chat box. Okay, there are no further questions. If there are any, please feel to type in your answer in the Q&A directly. So with this,
Thank
we
you.
come to an end for our oral presentation. I would like to thank all our presenters for dwelling into a wide range of topics ranging from self-reliance to health information systems to HIV control and for the little book of delivery. So I would like all the presenters uh, for their engaging. I would like to thank all the presenters for their engaging presentation. We would break for 20 minutes. In 20 minutes, that is 12 p.m. IST, we would rejoin for our panel. The panel will dwell into the sub-theme of HSR 2024, Knowledge for Just Health System. We have some amazing panelists, Dr. Meghna Dhimal, Professor Mohan Datta, Dr. Tanya Sheshadri, and Latina Bilai, who would dwell into many topics such as radical listening, decolonizing health for justice, translating evidence into practice for climate resilient health system, and community and participatory action research. So I would request you all to join in 20 minutes and we would begin our panel then. Thank you, everyone.
Hello, everyone, and welcome back to this pre-conference. We would now begin with the next session on our expert panel on knowledge for just health system. For moderating the session, I would like to invite Iman Hamid. Iman Hamid is a consultant for Access Health Southeast Asia. She has a diverse background ranging from biomedical and life sciences to public health policy to the role. After spending over a decade of a career in the lab investigating the properties of silkworm and spider proteins and conducting microRNA research on liver and bladder cancer, she was inspired to make a shift to public health. Iman pursued her Masters of Science in Public Health from London School of Hygiene and Tropical Medicine and conducted qualitative research in Sri Lanka on barriers to health access in 3 fishing communities. She also worked with Public Health Pathways as a public health researcher and trend reporter. She has a desire to work with marginalized community and improve access to healthcare in low and middle income countries. So over to you, Iman.
Thank you, Kate, for that wonderful introduction. Hi, everybody. Happy to be here. Hope you enjoyed your break. Welcome to the panel session of this pre-conference. I'm very excited to be here because we've got 4 excellent speakers whose combined talks will provide us methods and approaches to build knowledge towards just and sustainable health systems. As mentioned before, we will be introduced to radical listening, the need for participatory action research, building a culture-centered approach to transforming structures, and how to translate evidence into practice. Now, before we move on to the actual session, I just want to mention that the flow is going to be that the panelists will present their work first and one after the other, and then we will proceed to a panel discussion. But feel free to drop your questions during the talks in the Q&A box. We will then select some of these questions across the talks to be asked at the panel later on. So without further ado, I would love to introduce our first speaker, Litania Belai-Jandam. She is a climate officer from Healthcare Without Harm, Southeast Asia. Belai is a climate reality leader and indigenous environmental activist from Indonesia who recently graduated from the University of Sheffield, UK, with an honours degree in medical sciences. She brings a wealth of experience from international non-profit organizations specializing in climate and health. As an indigenous youth, Belai grew up surrounded by a traditional wisdom that calls for the protection of both nature and culture, which has translated into years of activism across local, national, and international platforms, including the last 4 UNFCCC climate conferences. Belai is passionate about integrating a systems-oriented approach to planetary health and empowering healthcare professionals to become climate leaders. Additionally, she is a dedicated advocate for Indigenous rights, youth empowerment, and community-based forest management in Borneo. Belai, over to you.
Thank you so much, Iman, for the kind introduction, and good afternoon, everyone. Thank you for inviting me to be a part of this conversation, and I'm very excited to be a part of a group of incredible panelists talking about knowledge for just health systems. Before I start, I'm going to quickly check if you can see my screen.
Yes.
Okay, perfect. Thank you so much. So yes, as you know, my name is Belai. I'm an indigenous climate and health practitioner from Indonesia, and I'm currently working in a nonprofit called Healthcare Without Harm as climate officer, but I'm also an associate board member of the nonprofit Health in Harmony. Today, as we talk about knowledge for just health systems, I wanted to introduce an approach that is practiced by Health in Harmony and their sister organization, Alam Sehat Lestari, or ASRI, in garnering, understanding, and operationalizing knowledge for just health systems. And this is an approach that we call radical listening. To give a bit of an outline of the presentation, I will quickly touch on planetary health as a concept and a framework for just health system. I will go to the implementation of planetary health itself, taking a case study from Health in Harmony and ASRI's work in West Borneo in Indonesia, and then to radical listening itself and how we can use this as an approach to garnering understanding within the planetary health scope. And then moving forward, what are some of the skills that we can take from this session and from radical listening that I hope can be implemented by researchers and especially health researchers and health practitioners worldwide. To start off, I thought it would be good to just lay down this question for everyone to kind of reflect on. And the question is, what makes a just health system? Feel free to share your thoughts in the chat if you would like. But I wanted to lay this question as a start of the presentation because when we have a panel talking about knowledge for just health systems, but it's important that we have a shared understanding of what that means to us. And when we look at the components of health systems and we see that through the lens of justice, I'm sure there are many things that are going to come up when we are asked this question. But one thing that I wanted to highlight about what makes a just health system for me is this idea of interconnection. Interconnection is such an important part of understanding justice and understanding health systems. And it plays in many different levels of the health system itself. For one, I think it's important to put interconnection at the center of our understanding of health, meaning that we need to be transforming how we understand health, that health is not just merely the absence of sickness and disease, but health is that holistic spiritual well-being, and that comes into the interconnection between our human bodies and our human body's relationship with the health of the things that are around us, including the life-giving ecosystems that support the lives of humans in this planet. The indigenous community that I come from, the Dayak people of Borneo, we believe in the life-giving ecosystems of forest and the role that forests play in addressing our health and kind of becoming a source and foundation for our health. And that's just an example of interconnection that I wanted to highlight. But on a different level of the health systems, interconnection is also about how do we then have our health systems work in tandem with all of the other sectors that exist around us? How can we interconnect health with education, for example, or interconnecting health with gender and human rights? So this is just something that I wanted to put out there as we go through the conversation today. What makes a just health system for you? And how does interconnection play a role in this understanding of a just health system? Now, as we talk about frameworks for a just health system, as somebody working in the planetary health realm, I find that planetary health is such a useful tool for understanding what a just health system could look like. And I've taken this graph from the Lancet Planetary Health Journal, an article that was published in 2021, titled A Framework to Guide Planetary Health Education. And just to give a brief overview of what planetary health is as a concept, we can see in the graph that there are 5 main domains of planetary health. The first and central one is that interconnection, again, within nature. And really, this is about understanding how our health is dependent on the health of the natural environment around us. And then on the side, you have the Anthropocene and health. And that's really understanding the anthropogenic factors that play into the health outcomes of and the ill health of the human population. We also have this domain of equity and social justice. Of course, as we talk about planetary health and the health of both climate and people, the planet and the people, we cannot talk about that in separation from equity and social justice, meaning that all of the work that we are doing to implement planetary health has to be putting at the center, leaving nobody behind and centering everything on justice. And then again, another domain, the green one, as you can see, is systems thinking and complexity. This is about how planetary health challenges a lot of the siloed approaches that we have to health today. And system thinking is about how do we think of health not as a sector, but as a system. And again, in connection with all of the other things that play into our health and well-being. And then finally, planetary health is about movement building and systems change. I think that planetary health can be a really, really useful framework as we talk about just health systems, because it provides an opportunity for us to challenge the current notion, the current systems, and our current understanding of health, and really going outside of that, really radically transforming how we understand health and radically transforming how we deliver healthcare, making it equitable and just for everybody in this world. Now, In order to understand planetary health, I thought that the best way to do it is to share a case study. And this case study comes from the organizations Health in Harmony and Alam Sehat Lestari, who I have had the privilege of working with, volunteering on site in 2020, and now being a part of their board member. And I remember hearing many different stories from when I was in ASRI, located in West Borneo. They work with the rainforest communities in the Gunung Palung National Park. And one of the questions that came up when I first learned about the work of Health and Harmony in ASRI is this question: how many trees do you need to deliver a baby? When you hear this question, you might think, what am I talking about? What do trees have to do with delivering a baby? But this was a story that came up in Health in Harmony and ASRI's work that really kickstarted their practice of planetary health. And you'd be surprised that the answer is about 60, or at least that was the amount of trees that a man had to cut down in order to pay for his wife's cesarean section. This is just one of the many ways in which we can see this complex relationship between human and environmental health. And when we talk about climate and health, I think we often focus on how a sick planet can lead to sick people. But an equally important part of this discourse, and this is something that ASRI and Health in Harmony was able to discover, is equally how do sick people lead to a sick planet. Through their work with the rainforest communities in West Borneo, they learned that deforestation in the area was actually driven by a lack of access to high-quality, affordable healthcare. And the limited options to sustainable livelihoods put many community members in the difficult position of having to choose between their short-term and long-term well-being, knowing very well that the health of the forest around them are foundational to their health. Through learning from the communities, ASRI was able to implement many unique cross-cutting programs that I think are a very quintessential example of what planetary health in action could look like. The first thing that they learned from the community is, in order to stop or reduce deforestation, there needs to be affordable and high access to affordable and high quality healthcare, which is exactly what they did. They built a clinic in the area. You can see the rainforest in the back of the clinic, which offers many different health services, from midwifery, dentist, ambulance, monthly health examinations, and including a mobile clinic. Another way in order to make this more affordable is that they have tiered healthcare discounts and non-cash payment option. When I learned about this, I think this is one of the very few clinics in the world that actually offer the option of paying not in cash for receiving healthcare delivery. And you can see from the poster that the other options is to pay with seedlings or handicrafts, rice husks, animal manure, or labor. And in order to further incentivize the protection of rainforest in the area, they offer tiered healthcare discounts through a monitoring process, where if you are a patient that comes from a village that has reduced deforestation rates, then you can get up to a 70% discount, for example, which incentivizes that link between rainforest protection and healthcare delivery. Another unique approach and we have is chainsaw buyback, in which they help support former illegal loggers to switch to a more alternative and sustainable livelihoods by doing interest-free microloans, technical training, and financial management education. And there are plenty other programs that I will not go through in detail that show just how unique planetary health in action can look like, from education, from awareness raising, to farming, to sustainable livelihoods, even a program called Goats for Widows and chainsaw buybacks. This is what planetary health could look like. And what I wanted to highlight in today's presentation is, how did ASRI get to this moment? How were they able to create all of these links and design solutions that are very much fitting for the context of the community? And the answer is, they did it through a process called radical listening. Radical listening, in the context of our conversation today, is a useful tool when we talk about how do we produce knowledge for just health systems. At the core of it, radical listening really is about centering communities as the experts and working alongside a community to support them as they wrestle with all of the interconnected problems that exist in the community and eventually come into an agreement about the solutions. And there are three core beliefs that guide how radical listening is conducted in Health and Harmony and ASRI. The first one is the belief that humans everywhere would not only like to thrive in the present, but they also yearn for conditions that allow their family, community, ecosystems, and the planet to thrive far into the future. And it's that long-term longevity that guides our principles of radical listening. The second belief is this idea of interdependence. Again, we do not listen in silos, we listen interconnectedly, and looking at how the human and the natural world are deeply interconnected and how planetary health fully depends on honoring this reality. And then the third belief is that those who are closest to the challenge, closest to the pain, are those who are best equipped to determine the solutions to their own problems and to implement these solutions. Now, these might sound quite logical when we talk about approaching our a community-based approach to working on planetary health, but we found that in applying radical listening, there are a lot of paradigm shifts that we are offering, especially in this world of research and community-based work. Some of the ways in which we are shifting those paradigms is first changing from this idea of we are separate to we are interconnected and interdependent. This includes, for example, how we see the relationship between forest and livelihoods and healthcare delivery, and seeing that things are not working in silos at all, especially when it comes to working with frontline communities. Everything works systems-orientedly and everything works interdependently. And that's a paradigm shift when it comes to radical listening. Another existing practice is that there's this idea that the outsiders knows best. Maybe we are a very talented and prestigious researcher coming into a community. And of course, there will be this idea and belief that we have the expertise and we have the experience and knowledge to solve whatever challenges are being faced by the community, but there's a paradigm shift from that to the local community knows what's best. That's something that we practice in radical listening. It's letting go of that control and trusting the community to tell us what the challenges they face are and what are the best solutions to do that. And then the last paradigm shift is in terms of specifically nonprofits working in this space. There's a lot of ways in which our work is guided by a charter, and that charter determines what will be done, right? I'm sure everybody's quite familiar with this as well, but there's a difficult but necessary paradigm shift in the sense that when we listen to communities, when we listen to communities' collective intelligence, they should be deciding what to do, and the NGOs should be supporting them, whether that's not just NGOs, but governments and individual researchers. We shouldn't be dictating what solutions need to be done by the community. Once they understand the challenges and they tell us what the solutions are, the paradigm shift is that they determine what to do based on their expertise and their experiences, and we can support them from many different aspects. Now, how is radical listening different from other listening methodologies? To start off, radical listening is complementary to all of the things that we will be hearing in the panel today, as we will be listening to many different experts about approaches to knowledge for just health systems. So it's very complementary with the work that radical listening is doing. But some of the distinctions that we can make is, for example, compared to active listening methods. Radical listening is a form of active listening. However, active listening is generally thought as a process to listen to an individual attentively, whereas with radical listening, we are working with communities. And so there is this sense, there's a different approach when it comes to listening to an individual versus listening to a group or to a community and the dynamics that come with. The second one is compared to participatory methods. Sometimes when we approach a community with a participatory method, there is already this hypothesis in a sense, or an idea of what the outcome will be like, and receiving feedback from the community will consolidate that idea. And sometimes that approach is necessary. But what we are doing with radical listening is the community get to determine the solution themselves and refine the work as needed. And they get to create the hypothesis, and they get to tell us basically what to do. And then the last one is in comparison with facilitating methods. I think it's also a form of facilitation, but again, what radical listening does differently is that there's this process of letting go of a predetermined outcome and trusting the community in that process. And we call it radical listening. So what makes it radical, right? And all of the things that I mentioned earlier is what makes it radical. But if I can boil it down to 3 points, first is that communities are centered as the experts, meaning that we are letting go of that control when it comes to determining what the challenges and solutions are, and we're centering community expertise in this dialogue. Second is it has to be connected with investing precisely in their solutions. What makes radical listening is that we don't just stop in the listening, we continue that work by investing precisely in the solutions that come up. We don't decide what the solutions are, we listen to the communities and invest in what they believe are the right and necessary solutions that are fit for the context of their community. And the underlying process is that radical listening is an iterative process, meaning that it's not a one and done. It doesn't happen just one time and then we're finished. It is a continuous process, whether that's from the initial conversation with the community, whether that's when we start getting into surfacing the problems and challenges of the community, whether that's later in the implementation of the solutions itself. Every step of the way, we do radical listening as an iterative process in order to make sure that what the community is feeling and the feedback from them is continuously incorporated in our work with them. Now, if you would like to read about the impact of radical listening, there is a very Health in Harmony and ASRI published a paper in the PNAS in partnership with Stanford University, studying how radical listening and the community design solutions that were implemented in their first site, which is the site of ASRI in West Borneo, has led to many different impacts. And this is a 10-year study in total. And from gathering all of these data, I won't go too detailed into the methodology of the study itself, but some of the main findings from this paper is that because we did radical listening, because we were investing precisely in community design solutions, we saw a 90% reduction in logging households. We saw a 67% decrease in infant mortality. We saw almost over 21,000 hectares of secondary forests regrown and reforested in the area. And this is worth about $65.3 million worth of carbon dioxide equivalent emissions averted because of this work. And really, the bottom line is that we're learning health and climate can and should be addressed in unison. And this work has to be done in coordination and in respect for the local and indigenous communities where we are working at. And to close off, I just wanted to highlight some of the key skills for radical listening. And I think that this is applicable in many different contexts as well. So I hope that some of these skills resonate with you and are skills that you can take as you work within your research, within your scope of work. The first one is there needs to be a skill of embracing interbeing. And what this means is interbeing between the listeners and the community, but also interbeing between us human populations and the natural environment around us. So this embracing interbeing is about listening with curiosity, with open-heartedness, with respect, and with a systems-oriented approach in mind. The second one is the skill of cultivating presence. And this really has to do with equipping the researchers with the cultural competence before going into a community. So as part of the radical listening process, we have like a like an initial scope study where we learn first about what are the customs of the community, what are some of the ways of living in the community, what is the culture like, and that's about building cultural competence within the researchers before going into the research and the community itself. And we have to be cultivating presence in the sense that there is this sense of respect and trust as we go into the community, and we position ourselves as equal, not higher, not lower. And then the third skill is building rapport. And
I will need to wrap up soon. Thank you.
okay, I'll close off in a little bit. Building rapport. And what I mean by this is, how do we showcase through our body language that we are ready to receive knowledge from the communities? I think this is also a big part of training to become good radical listeners, is building that rapport and building that trust with the community, showing that through our verbal but also body language. The fourth one is being able to remember and reflect. Again, this is the part of the iterative process of radical listening, which is that it is a continuous cycle that is not a one and done. And how do we remember and reflect that continuously in the process? And then finally, relating to emotion. Okay. And then just to close off, radical listening is an approach that needs a long-term and decolonial mindset, centering it on the communities that have paved the way for our understanding of climate and health, and looking at it from a long-term sustainable lens. Okay, I'll close up there. Thank you so much.
Thank you, Belai. We will move on now to Dr. Tanya Seshadri, and she'll be speaking to us on participatory action research. Dr. Tanya is a community health practitioner and researcher, has been with the Vivekananda Girijana Kalyana Kendra, BR Hills, Karnataka since 2012. She was instrumental in setting up the Tribal Health Resource Center and is involved with overseeing the hospital and community health program catering to the Soliga and other tribal communities in Chamarajnagar district. The center is also involved in collaborative research and action on sickle cell disease, hemoglobinopathies, zoonotic diseases, and addressing other health problems among tribal communities. In collaboration with the IPH Bangalore, she is currently co-leading the establishment of a multi-institutional research and training center for action on tribal health called the Center for Training, Research and Innovation in Tribal Health under an award from the DBT Wellcome Trust India Alliance. So without further ado, I'd like to welcome Dr. Tanya with her participatory action research talk. Over to you.
Thank you so much. And what an honor to be part of this panel. And much of what I must say, the first speaker spoke about, I think applies to everything that I'm going to talk about. So thank you so much for timing it like that as well. So I'm a researcher, health practitioner working in South India, and I have had the opportunity of working with an indigenous community for over a decade now. And all the work that I'm going to be talking about is from this journey that we have had. Sorry. So building the context of the people that we work with, the Soliga people are one indigenous people in South India, and much of what the first speaker spoke about, resonates a lot with also the way people here, the Soliga people think, view, and approach both their lives, but also the way they access health, the way they view the cost for them for health services. Now, within India, if you look at the history of the indigenous people, like the Soliga people, I think what has always been very obvious across all policies and departments has been the wealth of natural resources that have been around. The forest, the minerals, the water. So everyone has always viewed the indigenous people as poachers, encroachers, exploiters. That's often been the perception. Over time, with conversations of climate change, with conversations of biodiversity, wildlife protection, conservation, etc., the people have then been viewed as those who are standing in the way of, let's say, tiger conservation or better forests, elephant corridors. And so there is a history of displacement, history of relocation in the name of the larger good for the country. And this has been happening since the 60s with not much, with zero conversation with the people themselves. It was only as recent as 2006 that the rights have been awarded to the people over the way they stand over use of natural resources, both as individuals and communities. But yet, when you look at the health system in India, the health system has continued to view the indigenous people only as economically poor, so those below the poverty line. I think the health department is probably the only people in the nation who can't see the forests, who can't see the the biodiversity, who can't see the way the different policies have been influencing and significantly affecting the people and their lives here. And at the same time, a push for more community engagement within health policies has opened the door for various societal injustices to enter the health system. And without addressing or without opportunity to address this, without prioritization, what we also see now within the health system is that because there isn't much thought, because it is not viewed as a problem at all, and therefore we don't have to do anything to solve it, that even within the health system, when there is a conversation with the indigenous people, when there is a talk about what can we do, how can we do, that there is actually no one listening or no one who thinks it's important to listen. Also, number-wise, because our health policies are very majoritarian focused, vaccination coverage, we've also landed on Mars. So there is this image issue, there is an identity issue, where the government wants to bring in more and more technology, want to become more and more efficient and effective. And therefore, we have on one hand that kind of conversations, and then we have the Soliga people where in many hamlets still they do not have public transport, they do not have electricity. So conversations of access to health are still very far away from where they are. Now, coming to our work and how we came about, how we started with participatory research. Initially, some of us were doctors working here, and there was this constant, from what we read and what we see, there was a constant need for a lot of relevant and local customized questioning that we kept recognizing. But often when we tried to engage in research, there weren't many takers for working on with indigenous communities, or even numbers wise, because they're very small numbered within the Indian population. So people would say we want studies with 10,000 deaths are studied, and here the number of the people themselves may be about 10,000. So the whole number approach and also the prioritization, we were often asked to be just a site, but someone else, sitting in Delhi at the national capital or sitting abroad, they frame the questions, they decide how the study should be done, how it should be conducted, what is relevant, the analysis is done by them. So very slowly we recognize that if we really need to do more relevant research that's also responsive and that also addresses the local inequities that we view, that we needed much more control over the research itself, but we also needed to move towards methods that allowed for more local conversations and also reflexivity, the question of positionality and all coming in. And that's how we started moving towards participatory methods in 2014. But of course, some of the challenges of moving in this way, of course, is the messiness that that comes into many of the our routine research conversations. Like one of the first conversations we had with the Indigenous Peoples Collective, for example, where we were very confident that okay, we're going to be doing a participatory research method. We will frame the question together, and the only thing that they were interested in was in the project management. Okay, who's the donor? Where is the funding coming from? What are your budget heads? What is your timeline? How are you going to do it? Who's the decision maker for fund utilization? And that's when we recognize that when we talk about participatory research, that we actually had to start from there. And eventually we have moved towards having partnerships both in planning the project itself, the research management. Of course, there is also collaboration in the kind of questions that are being asked, community discussions, and then questions, our next question or our next work often builds upon the previous one. So there also that opportunity. But then also the issue of generating, in this effort to ask questions, what we see, there's also a need to, help someone in responding to what we see on ground also. So because of this, a lot of collaborations with NGOs, with community collectives, many of the people who were subjects of the first work that we did today are part of the research team. So, but a lot of emphasis on training there. But then, the traditional struggle, for example, there is a large cohort study, one of the first of its kind with indigenous people in South India that we have undertaken. But the cohort method just being so tough to implement, also when we have the issues, the failings of the health system also eventually come into the research as well. So trying to transport one blood sample from a hamlet to the lab, maintaining temperatures, etc., because there is no regular health system. So many of these issues keep coming in. But then with, these are just some of the works that we have done. And today we had, our methods have also gotten better. So we are working, we have much more collaborations, much more partnerships. The Indigenous Peoples Collective is also often a collaborator. But then when COVID came, so the COVID for us also exposed, I think for everyone in a very loud and in a very visible way, the mistrust between the indigenous people and the health system. But what it provided us locally as an opportunity was that the health system for a change actually opened, the health services opened up and said, we are open for collaboration with community and with NGOs and with researchers. So there we had this opportunity of where there were reports of indigenous people running away into forests when, because we had a policy of mandatory institutional quarantine. And this was triggering for many people, the forced displacement, forced relocation that their fathers and grandfathers had undergone. So we came together in conversations, and the same principles that we had used in our research, we brought them into the health services intersectoral department coordination happened, and we were able to help the district in starting its first Indigenous Peoples COVID care center, which was managed by the people, but supervised by the health system. And similarly, even when it came for COVID-19 vaccination, more the misconceptions and the perceptions within the health services of that the indigenous people will not be open for vaccination, or this is very high technology and they do not understand science. So with the Community People's Collective, they asked us for a partnership, and we sat together, we reflected on, we used this as an opportunity to spark a discussion and to talk about, the rights of health, the rights to health, a conversation of, if we were to do this, how would you like this to happen, like a vaccination campaign. And this was centered around, so the people came out with one of their traditional folk arts method of song, dance, and theater. And we use this, and no digital technology, but literally a troupe moving from hamlet to hamlet, sitting with people, having conversations, arguing. There was a lot of dissent, there was a lot of debates. But at the end of the day, when people made their decision, they had all the information and they made it by themselves. And we're very happy to share that, it took us 6 months longer than a traditional, universal vaccination campaign, but 100% vaccination happened. So much of what we learned, we recognize very quickly, and even now it's a very important part of every work that we do, whether it's advocacy with the health services or whether it is sitting with this with the community as well. And I think the previous speaker also spoke about this, was the first question on for whom are we really generating the knowledge. And initially much of our experiences in India, especially with tribal health, with indigenous people's health, is that we have, central governments, state governments, commissioning reports. We have universities and academic organizations who participate in, some grant, and then they come and they ask for, give us this survey, give us this data, give us these blood samples, and, we'll publish papers. And so we ask these questions every time there is an opportunity. We sit with the people and we make sure that even the data, the information that is generated, there is the soft learnings through the research itself, through the method of research, and then you have the findings that, of course, there may be the traditional publications, etc., but that much of this has to go back into practice. So by collaborating with multiple organizations, including the government, we try very hard to make sure that people have access to this information, and that we continue these conversations. So over time, slowly, what we have is a very long relationship. The community, like the question on who generates it. So now much of the team itself, there are people who come in from the community, who are now part of the research team, etc. And on one hand, that brings in an internal questioning where we, many of the people get called out on for, oh, you're asking this kind of a question, but it's based on these kind of assumptions. And so it is messier, it is slower. And of course, the biggest conversation we have with most of the, the funding organizations, with most of the donor organizations is, there is always an aim for efficiency on using, 100 rupees in the best way possible to get the best impact. So we work very much on, orienting and preparing them also for this journey, so that the learnings and the collective learning that happens, that is also valued. Most importantly, again, like the first speaker said, definitions are often restrictive. And so we have recognized over time that when we are co-producing or co-designing a study with our community collaborators, that we cannot go with preconceived designs or preconceived ideas of this is how it will be, but rather being open to things emerging from there. And today, with the field building that is happening in health policy and systems research across the globe, we find, very also radical listening, what she said. So we find very inspiring and very flexible, very reflexive methods where the principles of restorative justice or cultural safety are already inbuilt into these. So we are also moving slowly towards encouraging and asking questions and encouraging more local health systems work where these are built into the methods itself. Yeah. So I think that's about my time. So I'd really like to thank, of course, the Soliga people with whom I have had the opportunity of working for over a decade, but also my teams at the Institute of Public Health, the local NGOs, our government partners as well, for being a part of our journey all this time. We have had a lot of ups and downs in our relationships due to mismatch of expectations as well. But over time, by keeping our principles, at the heart of all our work and conversations, I think today we are a much better collaborative. We are able to work across the entire district. It's it's the smallest administrative unit in India, and today we have become a place of learning, a field of collaborative, community engaged, participatory learning. Thank you, everyone.
Thank you, Dr. Tanya, for that enlightening talk. And really love the part about slow research. And I'll come back to that when we have our panel session. But moving on to our next speaker, I'd like to now invite Professor Mohan Datta to talk about decolonizing health for social justice, culture-centered approach to transforming structures. Professor Mohan Datta is Dean's Chair Professor of Communications. He's the director of the Center for Culture-Centered Approach to Research and developing culturally centered community projects of social change, advocacy, and activism that articulate health as a human right. Professor Mohan Datta's research examines the role of advocacy and activism that articulate health as a human right. His role of the role of advocacy and activism in challenging marginalized structures, the relationship between poverty and health, political economy of global health policies, mobilization of cultural tropes for the justification of neo-colonial health development projects, and the ways in which participatory, culture-centered processes and strategies of radical democracy serve as axes of global social change. He is interested in theorizing the nature of productive practices of academic performance situated at the intersections of subaltern politics, activist commitments, and academic research. Professor Datta explores these tensions in academic activist community collaborations through his own experiments with collaboration and solidarity. Without further ado, inviting Professor Mohan Datta with his talk.
Kia ora koutou katoa. It is lovely to be in this space. I come to you from Aotearoa, New Zealand. I want to begin by acknowledging the people of Rangitane, on whose land I sit. And it is a reminder that the ongoing displacement and erasure of Indigenous people and communities forms the infrastructures in which we produce much of the knowledge. Today's talk is framed around a conversation on decolonizing health for social justice. And I want to grapple with the culture-centered approach as a framework I've been working since the mid-1990s, based upon my work with the indigenous people or the Adivasi people of the Santalis. And growing from that then in terms of building indigenous collaboratives across global spaces. In delivering this talk, I want to acknowledge the two earlier speakers. I think you will find a lot of resonance here. I will also critically interrogate some of the concepts that we talk about within these spaces of justice and public health, particularly ideas of community, ideas of participation, and ask the question, who defines community, who defines participation, and under what kinds of logics, ultimately arguing that to bring about processes of change calls for us to place our bodies on the line. I begin with a short excerpt from a poem by an activist interlocutor who is no longer with us, Abhay Saksa, who is an Adivasi activist and scholar who has passed away. And Abhay wrote a beautiful poem, and I'm just reading part of the poem, where it says, and I quote, "I'm not your data, nor am I your vote bank. I'm not your project or an exotic museum project. I'm not the soul waiting to be harvested, nor am I the lab where your theories are tested." I think, end quote. So this is a longer poem, but I think there is a lot of provocation there in terms of the language of project, the language of project management, the language of funding. And I want to sort of build this talk around this question: can we bring about radical change through NGOization and NGOs and civil society and projects funded by funders in the global north who are wanting to lift the burden of the soul? And I want to engage that within this question of what does decolonization mean, and argue that decolonization is fundamentally anti-colonial, anti-imperial, and anti-capitalist. In doing so, I want to begin by acknowledging the ongoing genocide that we are seeing in Gaza, carried out by the settler colonial state of Israel. And it demonstrates to us powerfully how fundamentally every aspect of health is threatened and destroyed as a settler colonial project works alongside empire to carry out its extractive infrastructure. I'm just going to share sort of four readings from the body of work on culture-centered approach. I'm going to share the slide with the team so you can have access to these readings. These will give you access to more readings. In this talk, I'm going to first talk about what is the hegemonic approach to health communication, and how the project of health communication and public health intertwined with colonizing structures and processes, and how do we play the games of metrics and the games of funding. And then really ask from within that, then what does it mean to build Asian imaginaries? Now, notice that I theorize much of this within the context of my own positionality in India, within the broader landscape of Asia. Therefore, I ask, what does it mean to engage with questions of caste and caste privilege? What does it mean to do anti-caste work when engaging with questions of Adivasi politics? How do we interrogate our own interpellation within the caste structures? And how does it connect with the politics of Hindutva, which is a far-right nationalist cultural project that seeks on an ongoing basis to co-opt the Adivasi identity in order to further perpetuate the project of Hindutva. So these are critical questions for me as I grapple with this anti-colonial politics. So I want to begin by asking the question then, when engaging with the notion of decolonization, how do we ask, what does it mean to theorize? Who defines theory? Who has the capacity to theorize? At a very broad level, one can argue that the global north has historically done the theorizing work, while the global south has lent the bodies to be theorized over. This, however, needs to be complicated, because within the global south exist inequities. There are inequities of gender, inequities of caste, within South Asian context, inequities of social class, so that within India, for instance, you have upper caste, largely Brahmin scholars who theorize about decolonization and post-coloniality, while Adivasi bodies become the bodies to be harvested and written on. So my work then aligns with the work of scholars like Olufumi Taiwo, who argue that we need to also interrogate the superficial identity politics of decolonization that moves us away from engaging with questions of capital and inequalities that exist within, and recognize that within post-colonial spaces, post-colonial elites are always almost in collaboration with imperial colonial capitalist elites across the global north. So in this piece, which looks at what does it mean then to theorize the global south, published with Dr. Mahua Pal, I argue that the work of theorizing from the global south is fundamentally about dismantling the infrastructures of knowledge production that uphold hegemonic configurations. And these hegemonic configurations are shaped by the rules of whiteness as the rules of dominant white culture that take for granted ideas of this white culture as norm. So the idea that humans are only to be counted to the extent that they own private property. So in my earliest work with Santalis, for instance, when Santalis describe their health as intertwined with forest, because the spirits live in the forest, and that is how they see their interconnectedness with health. Or when, in our work with Maori, within the context of Kaupapa Maori theorizing, Maori articulate the notion of health rooted in whenua, the land, and relationship with whenua. Those become ways of radically reimagining what does it mean for us to conceptualize health, because they fundamentally disrupt the whiteness of health as a private property to be individualized and located within the individual. But here's the question. If then you acknowledge that health is about the forest and intertwined relationship with land, the natural outcome of that in terms of the work of health communication and health advocacy is the struggle against land occupation, land grab, and struggle for land justice. That means, or that calls for us to place our bodies on the line to resist the colonial project and the extractive capitalist project within the spaces that we inhabit. So as Tanya beautifully pointed out, I mean, and I go back to the words of the Indian activist Arundhati Roy, who said that the pandemic is a portal. And, I have this image of COVID. But I think, one of the things that COVID makes visible quite powerfully is the interplay of colonialism and empire in terms of how it shapes the marginalized conditions that shape poor health. And this is tied to logics of whiteness that are fundamentally anchored in US-centrism and notions of individualism, cognitivism, rationalism, and linearity, so that public health or health communication becomes one of message centrism, promoting the right message for the right audience to promote the right behavior with the community to be saved. Unfortunately, in a large number of so-called community-based participatory research projects, this becomes the norm. So working with indigenous communities, they are turned into targets through, of course, now participatory logic. So everyone is participating only to become targets of interventions. And at the end, this supports and upholds and reproduces the capitalist project, because there are capitalist logics that are fundamentally intertwined with this. So to think about or to theorize health, then we need to look at the ways in which settler colonial violence fundamentally threatens human health and well-being, the ways in which profit extraction constitutes the processes through which indigenous communities are marginalized and displaced on an ongoing basis, and tied to that are processes of labor exploitation and destruction of ecosystems, precarization of work as indigenous communities are expelled from their spaces of livelihood. They are then introduced as hyper precarious labor in global production chains, and simultaneously the ongoing processes of privatization of community, of land, of public resources, and of communicative resources. So I argue in my work then that whiteness continues to persist across Asia, and logics of whiteness continue to persist across Asia as we think about engaging with questions of global health. So even though we do a good job of talking the talk of decolonization and global south, it is all that cachet right now, we continue to produce the metric games of the global north. So I spent a lot of time in Singapore, and I taught for 6 years at the National University of Singapore. And it always amazed me in terms of the messaging and the imaging in that context, in terms of how much that appealed to notions of whiteness. So, and that seems to replicate within academia, particularly in terms of how metrics of whiteness are then adopted into the Asian contexts, and the ways in which the racist ideology of whiteness shapes the hierarchies that we inhabit. Culture, therefore, is introduced either as an afterthought or as a hegemonic cultural essence that can be managed in the form of cultural sensitivity campaigns. So to actually challenge this then is to talk about the ways in which we can foreground structures, analyses of structures, and the ways in which we can mobilize to transform these structures. So the meta-theory of the culture-centered approach argues that health is situated at the intersections of culture, structure, and agency. Structures as a system of organizing of resources and systems, culture as values, meanings, interpretive frames that we draw upon, and agency as our ability to make sense of the structures and to enact everyday choices of life. So that interplay of culture, structure, agency then shapes communicative inequalities, meaning the inequalities in the distribution of voice and communication resources, such that those who are systematically marginalized often lack opportunities for representing, opportunities for being recognized, and infrastructures for having their voices heard. So to actually talk about a politics of building these voice infrastructures is intertwined with building a socialist politics that fundamentally looks at how do we redistribute health resources, how do we place resources or safeguard resources in the commons, And how do we look at projects of redistribution of income, education, shelter, and food? And this is particularly critical amidst climate colonialism, as indigenous spaces such as forests are turned into metrics within sustainable development goals that can be invested into as, for instance, carbon pits, as again, new systems of profiteering while indigenous communities continue to be displaced. So the work of CARE, I mean, we are very lucky to work with a team of researchers across the globe that run these community-led interventions. But the emphasis then is on activist interventions that seek to transform structures, and then really asking the question, how do we build movements from these voice infrastructures? So the work of building these movements then is fundamentally about addressing exploitative conditions. This is our work with hyper-precarious migrant workers in Singapore, for instance. And what we see within that context is to address the challenges of health is fundamentally about building spaces for voices where workers can talk about the poor living conditions. So amidst COVID, we saw how workers were stacked into dormitories that had between 20 to 25 workers within a room. And so how do we build these infrastructures where workers could organize and talk about their challenges with food insecurity or challenges with housing insecurity, and actually work to transform them in an authoritarian system that is organized to silence their voices and to deport a worker that actually speaks up? What does it mean to transform structures when we think about the hyper exploitation of workers? And I have the Amazon example here, but we can think of the gig economy. You know, we have been doing a lot of our work within the context of gig economy and thinking about what does it mean to organize workers within the context of AI, data justice, and platform justice. And again, this became quite critical during COVID times, as in much of our research across countries, we observed the ways in which these platforms left workers furthermore vulnerable in terms of their exposure to COVID pathways. So the work of then building communicative equality is about, you know, we talk her. Yep.
Sorry to interrupt you. Just to remind to wrap up in a minute, please.
Okay, I'll interrupt in 2 minutes. So what does it mean to build these voice infrastructures for communities to participate in decision-making processes? What does it mean for communities to own spaces of knowledge generation in terms that are meaningful to them, to produce evidence that are meaningful to them, and then to mobilize through that to challenge these structures? So we heard about radical listening in our talk. We have been talking about how do we build these infrastructures for listening, where listening becomes a way for bringing about social, political, and economic transformation in rendering impure the dominant categories of knowledge production. I want to wrap up with this slide that presents our work with the Deccan Development Society, which has sanghams or organized collectives of largely Dalit landless women farmers who organize to take back the control of the seed as a way for taking back health, as a way for challenging the neoliberal transformation of agriculture. So they sing songs to the seed as a way for challenging the neoliberal onslaught, but also as a way for safeguarding their health. So we will play the song, a little bit of a snippet, and then we will wrap up. Here they're singing songs to the seed as a way for transforming the structure of organizing food systems. So voice becomes a way here, voice through song becomes a way for transforming structures and bringing about interventions into those capitalist colonial formations. Thank you.
Thank you, Professor Datta, for that wonderful talk. And we'll come back to questions on this during the panel. And I'd like to now move on to Dr. Meghna Dimal, who will be talking to us on translating evidence into practice for developing a climate resilient health system in Nepal. Dr. Dhimal is an environmental health scientist with over 20 years of experience working in Nepal, Maldives, Timor-Leste, and Germany as a guest scientist. His primary area of expertise is on environmental health with a focus on climate change and health. He is currently working as a Chief Senior Research Officer at Nepal Health Research Council, Government of Nepal. As a principal investigator, he's led several research projects on environmental and climate change, NCDs, neglected tropical diseases, burden of diseases, and health system research in Nepal. He's also contributed to draft several policies and plans of health, population, and environmental sectors in Nepal and abroad. He's also the recipient of the Institute of Tropical Medicine Scientific Excellence Award 2023 and has been elected as a Fellow of International Science Council, which is the highest honor that can be conferred to an individual by the ISC. He has published over 300 technical reports, research articles in international peer-reviewed journals, including The Lancet, PMG, and Nature. Over to you, Dr. Meghnath.
Thank you so much, Iman, for your nice introductions. I'll confine to my time of 15 minutes. So I'll just share my experience of translating evidence into practice for developing a climate-resilient health system in Nepal. So basically, I'll talk about some indicators of climate change. Then I'll talk the broader impact of climate change on human health. Then I'll narrow down health impact of climate change in the context of Nepal. And then I'll share how we develop a resilient health system in Nepal using the evidence that we generated in Nepal. So we all know that climate change.
So sorry to interrupt. I think your screen is could you switch your screen maybe to the PowerPoint slides? I think it's not open right now.
Am I audible and visible?
Yes.
You're audible, but I think we just can't see your PowerPoint slides. So maybe could you reshare your screen again?
Okay.
So sorry.
Is it visible now?
Yep,
Yes.
perfect.
Okay. So we can see the clear trends and indicators of the climate change with like glacier are retreating, snow cover is decreasing, temperature over land is increasing, humidity is increasing, temperature over oceans are increasing, and air temperature near surface is also increasing. In the same time, sea level is rising, sea ice is declining, right? And different species are shifting towards the north. For example, mosquito, poisonous snake, etc. And different countries are preparing the different way, and even in the developed country are not well prepared. This year, the students in Australia made a campaign with the sick note. That means demanding the climate actions. And they have a climate and health strategy just this year. But many developing countries have just started the climate and health adaptation many years ago. So just I want to share experience of Nepal later. And the leading medical journal, The Lancet, has defined climate change is the biggest global health threat of the 21st century. And the World Health Organization has termed it as a climate crisis, as a health crisis, and should declare as a international public health emergency. And the signing campaign is on. The leading journal, The Lancet Countdown Report, published in 2023 November, conclude that if the temperature reaches 2 degrees Celsius already by mid-century, then the heat-related death will be projected to increase by 370%. And heat-related labor loss is projected to increase by 50%. And the transmission potential for the dengue is projected to increase by up to 37%. And we all have witnessed the surge of the dengue in the Southeast Asia with the more than 100 times increase in the last 10 years. So this year, the last year, 2023 is regarded the warmest year in the record of last 100,000 years. And such events will continue to increase, and the newborn baby will experience more and more heat than we experienced in the past. And there are the different impact of climate change. Some are direct, some are indirect, some are through the ecosystem, some are direct, like the heat wave, cold waves, injuries, etc. and also through air pollution, change in vector ecology, water quality, and so on. And recently, the biggest impact is observed in the mental health, also non-communicable disease. But especially from South Asia, there are very few studies, very limited evidence is available. And I'll not go in detail of all this, just want to highlight there are the several impact of the climate change, including infectious disease, non-communicable disease, mental health, injury, etc. However, there is a, ethical crisis. That means all the emitters are in the global north and most of the victims are in the global south. So who contribute 90%, they are the least burden of disease. But the global south, who have the negligible emission, they are at the highest risk of the climate-sensitive disease. So we need to address this ethical crisis. And if you see the publication, again, most of the publications are from the global north, where the impact is least, right? So we need to extend our collaboration so that we can generate the evidences and that evidence can be translated into actions. That's the motto. So back in 2008, I wrote an essay to the Lancet, the climate change and health research challenge for the vulnerable populations. And at that time, I documented that several challenges, like first was the lack of information and data. Second was lack of public awareness. Third was lack of trained human resources, lack of interdepartmental coordinations, low financial capacity, no political priority and focus on national policy. And geographical situation, like for a mountainous country like Nepal, very difficult to use the climatic data because of the microclimatic variations, and also lack of research methodology because most of the methodology developed in the global north, right? But today we have so many changes. We have the sufficient evidences to show that climate change is impacting in the global south and how the developing country like Nepal are suffering from the impact of climate change. And we made several studies, and basically our robust evidence are on the vector-borne disease and diarrheal disease. And in the rest, still we need to do a lot of research. I want to share some finding of the climate change and vector-borne disease, and our studies show that disease vector have already shifted above 2,000 meters. So now we need to change the terminology tropical disease because they are not anymore tropical, even in the alpine region with such cases, right? And we have conducted several epidemiological studies, social sciences studies, and all conclude that the vector-borne disease has shifted in the highlands. And also they have changed their seasons, not anymore seasonal, all are perennial. Even in the winter season in Kathmandu, we see the dengue cases now. And I just compared this finding with our neighboring country, India, China, Myanmar, and others. And similar pattern has been seen, means expansion of the vector-borne disease in the highlands of Hindu Kush Himalaya regions. And we conducted some systematic review and meta-analysis, which also conclude the same. And in case of diarrhea, several countries has reported the relationship between temperature and diarrheal cases like in Peru, Pacific Island, but there are no evidences. But now there are evidence from Nepal, India, Bangladesh, which clearly show impact of the climate change. Means with the increase in the ambient temperature, there is also increase in the incidence of the diarrheal cases. And the biggest impact is in the mountain region because these were not endemic in the past, but because the increasing temperature, more and more area of the mountain region are at risk of diarrheal disease. And in the past, if you see the IPCC report 2014 or 2007, nothing is written about this South Asian country, especially Nepal. But based on this finding, if you see the latest report of IPCC 2022, means there are several evidences coming from Nepal, which clearly show the impact of climate change in vector-borne disease as well as in diarrheal disease. And these are also reflected in the 10 new insights in climate science, which is usually shared before the COP28 meeting or during the COP28 conference of parties. Now, as the topic is climate resilient health system, I just want to highlight here that what is the resilience? Because we all know that there is a health system, there will be different stresses, and there will be a different level of vulnerability and adaptive capacity. So resilience means to decrease the vulnerability and increase the capacity, improve choice and opportunities. And if we can increase the resilience, means we can transform the system, or we can recover better than before, or we can recover to the pre-event state. But if we cannot develop the resilience, then our system may collapse. So our aim is to increase the resilience of our health system. So since last three talk, we are talking about the health system. So I don't want to go in more detail, but all the health system are based on the 6 building blocks. That means leadership and governance, financing, health workforce, service delivery, essential medical products and others. So based on that, WHO has recently revised the climate resilient and low carbon health system. So we need to develop the climate transparency, leadership and governance. We need to develop the climate smart health workforce. And we need to also improve the evidences through the climate and health research. And we must have the climate informed health programming. And also we must have the climate related emergency preparedness and management. So if we can improve in these 10 components based on the 6 building blocks, then only we can develop the resilient health systems. So I just shared in 2008, everything was lack of, non-existence, but now we have so many policies, right? Which has helped to mainstream the climate change in the health sector policy and plans. We are providing the training to health professionals. We are doing the inventory of the health sector greenhouse gas emissions, right? So several work, and we have the several research studies which document the evidence. So based on that, we have developed the Health National Adaptation Plan, which became the first SNAP in the Southeast Asia region. We scale up in other countries of Southeast Asia region, and Nepal is again the first country to update the SNAP. So we already have an approved SNAP for 2023 to 2030. In this way, we generate the evidence. Based on that, we develop the Health National Adaptation Plan, and our aim is to develop the climate resilient health systems. So this is my final slide. So what lesson I learned for my work in Nepal, Maldives, Timor-Leste, and other is that national capacity building is a key for adaptations. Otherwise, we get a funding, but we cannot use. And the international consultant come and go. And next, climate change adaptation and mitigation should be a priority of all countries. Even negligible emission, but we should work both so that we can access the funding from the Green Climate Fund and others. We must develop a climate resilient health system. So only the project doesn't work. So we should develop the system strengthening part through the system thinking approach. And more important is that developing a collaboration, networking, and partnership is key for reducing the global health issues such as climate change and One Health. And we have a health workforce and limited health workforce. They are not trained on the climate perspective. So we need to produce the health workforce to address the health risks of climate change. And finally, whether we say the One Health or the planetary health, but maintaining a planet health is essential for human and societal health and a precondition for a climate resilient development. So we must promote the planetary health. Thank you so much for your attention. And if you have any questions, queries, I'll be more than happy to answer during the panel discussion. Thank you.
Thank you, Dr. Dimal. So now I'm going to just move on to opening up questions, and maybe I will begin with one question and then pick a few across for the speakers from the questions that have been dropped in the box before. My first question, I think, is to Professor Datta, and this is mostly from a research perspective. There are many of us who are trained in the natural sciences who then progress on to public health research or public health policy work. And now, because of our focus on a very positivist approach, how can people like us, like even myself, be more aware and oriented towards the sort of whiteness that evades and pervades our culture, to be able to really understand and situate ourselves, especially when we don't come from our own lived experiences, and to know when to really, and to, this is a second two-part question, which is, what are the tensions between beginning as a researcher, being an activist, and where do we draw the line, and how do we know where to situate the harm between from a public health or biomedical perspective, you've got harms, but then from a cultural perspective, that may not necessarily be a harm. How do we really evaluate that tension, especially if you don't come from that community? I know it can't be answered in one go, but posing that question to you.
What a beautiful question, Iman. And you talk about our pedagogy, right? So my pedagogy is in engineering. I was trained as an agricultural engineer at the Indian Institute of Technology. So it's a highly westernized, technocentric framework. From there, I went into the social sciences, um, and was really constrained in terms of the methodological tools I had with me, or what I was trained into, right? In that sense, when doing my earliest work in the 1990s, I was saying amidst, Adivasi people, one of the things I started realizing gradually, two things. One is how ineffective I was. How ineffective were the methods that I was trained into in graduate school. They seemed to be totally useless in many ways, right? But the second part, and this is really critical, and which was really hard to face, is sort of facing the mirror. I grew up in what I thought was a progressive context, to face the mirror in terms of the ways in which that pedagogy itself shared the violence that I was part of. And that sort of taught me to approach the question with the logic of humility. So I would say that, part of the decolonization is decolonizing ourselves. And, I go to the work of Frantz Fanon, whom I had an opportunity to read much later. And, Fanon in his book, Black Skin, White Masks, talk about this process of recognizing our own colonizing processes that shape our thinking, and how can we gradually undo that. And part of that is to trust our embodied experiences. In Kaupapa Maori theory, which is theory created by Maori here, the idea is that you trust the land and your relationship with whakapapa, which is your community, your ties, those as the basis of your knowledge, rather than what the colonizer teaches you as the basis of your knowledge. So I think that calls for us to continually undo what we have been taught. So, one of the ideas of Cup of a Maori theory we have been working with is that you don't really write about indigeneity or indigenous health without being in struggle. So you can't really talk about decolonization without being in a land rights struggle against extractive processes. Otherwise, decolonization is just a fancy word which means nothing. So all this stuff about decolonizing syllabi and decolonizing our courses, they mean nothing if we are not ready to place our bodies on the line and agitate. But even as I say this, Iman, and I will wrap up here, I realize that I come with a lot of privilege. It is much easier for me as a full professor with tenure and with protections to talk about this. And I realize that for a lot of early career researchers, for women, there is also this negotiation of doing this work while needing to publish, while needing to survive and maintain economic viability. So there is this constant work of balancing. So thank you.
Thank you, Professor Datta. Well put. And I think that gives us all a collective responsibility as we move up to make space for those who are making their way up, to empower us, I think. So I'm going to move on to Balai. Balai, and I'm going to take on a question from the audience. They've asked, how are you looking at expanding this radical listening model to other parts of Indonesia? Have you documented, how it's been in other settings, in other areas?
Thank you so much, Iman, and thank you for asking that question. Firstly, I just wanted to share that there are resources available right now. If you would like to learn more about radical listening, Health and Harmony has actually partnered with Acumen Academy to create a course on radical listening. And I can share the link maybe in answering the chat question. It's free, it's online, and it's completely self-paced. And I think this is a great way to at least get an introduction to what radical listening is. And then on an organizational level, Health and Harmony also facilitates facilitates radical listening training when there is at least 6 participants within that training. So I'm happy to also share the contact point for radical listening or from Health and Harmony if you want to have any more queries about that. And I'm really happy that radical listening as an approach is gaining interest from a lot of people. I think it's important that we diversify our toolkit, as we can call it, in understanding and working with communities. And then in terms of scaling up, yes, we are thinking of scaling up in Indonesia and partnering with the Ministry of Health, but also our work is starting to scale up globally. As of right now, Health and Harmony has 3 project sites, all of them built in partnership with rainforest communities and on the basis of radical listening. The first one is the one where I volunteered and the one I'm most connected to, which is the ASRI site in West Borneo in Indonesia. But we also have a site in the Manombo rainforest in Madagascar and in the Brazilian Amazon, specifically in the Singu Basin River. The Single River Basin. So you could have a look in our website if you'd like to learn more about the other project sites that we have. But just in this conversation about scaling up, I think one of the biggest challenges that we are also trying to address is this issue of financing, right? We have all of these incredible community design solutions and expertise, but without the right funding and funding mechanisms, it will be hard to help these solutions live and to implement these solutions. And in resonance with Mohan's presentation earlier, there's also this challenge of many financing models still being very indirect and colonial, especially when it comes to community-based funding. There's a statistic that show less than 1% of all climate finance go directly to indigenous people and local communities. And that's something that we've been grappling with and trying to address. And so I'm happy to share that Health and Harmony is now partnering with Pawanka Fund, which is an indigenous-led fund-making effort, and also with the Woodwell Climate Research Center to create this platform called Rainforest Exchange, which is trying to address this issue of financing community-based, community-led, and community design solutions. And really the aim of this partnership with Pawanka and with Woodwell is that we continue to do our work in radically listening to and investing in the knowledge and expertise of rainforest communities, but all of this is done while centering self-determination. I think that's the key of the partnership, is that self-determination of communities. One of the ways that we do that is we use a data-driven approach to make funding schemes more just and inclusive. So I think, in my experience working in this space as well, a lot of funding or grants usually come with a long set of requirements and reporting and all of these different things that are just that is showing that what the success look like is determined by the funders, but also it's just sometimes impossible to put that expectation on communities who also have so many other things that they need to be dealing with. And so we try to implement this automated low burden, non-invasive monitoring system to take that responsibility away and to let communities focus on protecting the forest and thriving. And we measure that impact through 3 data sets. The first one is in terms of the carbon. The second was in terms of biodiversity monitoring. And the third one, which is something that we're still developing, is, but I'm really, really happy to share, is the community thriving narrative. This is where the self-determination especially comes in. We need to let communities determine what success looks like for them. We need to let communities directly receive funding for community-based solutions, and scaling up means centering all of that in self-determination of the communities. So yeah, I just to close, I do want to say that our work with radical listening, with Rainforest Exchange is a living and growing thing. We're still learning as well. It's not a perfect system. I don't think there is any perfect system existing right now. But that's part of the beauty of the process, is getting to learn all of these things with the communities that we partner with. Thank you.
Thank you, Belai. Professor Dr. Dimal, I want to ask you something in terms of, and this is again like the question I posed to Professor Datta, very much from researchers operationalizing all of this, on how to do this. when we want to translate evidence into practice, so, all the frameworks and looking at climate resilience, all of this, as a researcher who's understanding and bringing you the knowledge, whose role is it really to translate evidence into practice in terms of the ultimate practice? Where does the researcher stop, or do you stop at all? you know must we also advocate for, once our knowledge is put out and published, what then? Do we stop and continue only, or do we make sure that we push for it to actually be implemented? I'd just like to have your views on that.
Thank you so much for a very lovely questions, I'll say, because researchers should be very clear about the utilization of the findings. So as a researcher, we must be very clear. We should avoid the traditional approach and we should promote the interdisciplinary research, especially in a participatory approach. So if we consult with the policymaker and others in advance, and if they feel the ownership, and then chance for utilization of finding is quite high. One important point. Second, after the publication of the finding, researchers should not leave there. They should continue to do advocacy through the policy brief, writing in the media, and the role of media is very crucial. And if the general public or the policymaker realize the importance of that finding, then of course we can translate into practice. So political commitment is very important, and acceptance of the finding from the cultural perspective is very important, and the sustainability in terms of economic part and other is also very important. So if we can take the consideration of all these dimensions well when designing the research, and I think translating into evidence into practice is not difficult. But normally in the research, we don't see in the overall aspect. We just focus in one aspect, let's say social or economic, or only the like natural scientists, just the forestry part. But I think we need to make a interdisciplinary research for translation into the practice. Thank you so much. And unfortunately, I have to leave now because of my another meeting, which is pre-scheduled. And please enjoy your talk. Thank you.
Thank you very much for your time. I'll move on to Dr. Tanya, and I want to circle back on something that Balai was talking about. And I think because we're talking about, if you're talking about participatory action research, in fact, you mentioned time, and that was one of my questions really. Participatory action research requires an iterative process, and so does radical listening, for instance, as well. And this requires time, and if you don't come from the community that you're working with, relationship building, trust building requires time too. And then again, circling back to what Professor Datta talked about, a self-awareness and a reflection upon where you're coming from needs to be tied in. Having that awareness as you walk in, the tension and the struggle that you may have with who you are and what your perspectives are, that may be quite the opposite of someone, a community that you're looking at. All of this takes time. But our projects are usually funded by somebody whose turnaround time could be very different. And as early career researchers who might be in the audience, for their benefit, I'd like to pose, how do we work around time? I know it sounds like a very abstract question, but a necessary one, I think, because here we are, we want to do all this. How do we do it? How do we actually make time? Is there a way about it?
Yeah, thank you so much for that question. Making time is of course not possible. In this conversation itself, for example, it just, I think something that both two of the panelists mentioned about early career researchers, right? I think when we talk about the responsibility of research and researchers, I think it's also important to recognize that it's probably not every individual researcher in every individual research project who will be able to fulfill or who will be able to ask questions or will be able to engage. Because like what you spoke about, takes a lot of time, takes a lot of experience, and also takes sometimes, like the right team or the right space, sometimes the right opportunity. There are certain regions, institutions within where I work in India, where you cannot ask questions because of the institution's approach of policies, right? The way we have gone about, and let me talk about that, is by collaborating. And what's inbuilt into participatory action research is everything you spoke about. Through participatory action research, slowly over time, your relationship evolves. The identity and the messiness that is in the beginning, or actually, in the beginning, it always seems very clear. And the more and more you learn about yourself, the more and more people open up and the relationship builds. It's a bit like family where you're calling yourselves out. There's a lot of hurt. There's a lot of like, oh, I did all this and here's what you're doing. There's a lot of clash of expectations. So there is that phase that it goes through and it works. For us, what has worked is recognizing and shifting away our focus from expecting an individual research project or an individual donor from fulfilling that mandate. Rather, as a team, as a collective of researchers, as a network of researchers, now we are a collaborative as well. We have said that this is going to be our aspiration for the next 10 years. And so now we see individual projects and individual questions as things that plug in or things that provide, small pieces of the puzzle. So when a PhD student comes in the first year, for example, and let's say this student is not even, does not speak the language, has never even engaged with this kind of a method, then, like in the first year, then this person, we help that person in figuring out where they come in. But the good thing about this is by not fixing your aspirations onto these individual projects and all, the problem is, of course, the fact that because of these interruptions with funding and other things, things become slower, right? And so as long as we're doing it together, like with the community right at the beginning, we created a consensus on how we will go ahead. So that when we are slow, when things aren't meeting expectations also, that everyone recognizes this. So we come together and we review this every time. And every individual researcher, then we ensure that they don't get frustrated by, sometimes the conversations we have, the first hour of the conversation only, they feel like, okay, I'm not going to get this. It's too much for me. But then, and something that Belai said, as they go through this journey, especially with so many in our research team are from the community as well, over a period of time, this us, them, this they, respondent, us, all those boundaries change. You can see that happening. And then within the researcher, the minute that, there's a moment and you can see that, that light bulb going off like that, after that, we have no responsibility anymore. They'll take it ahead on their own. So the beauty of this kind of building a collective, of bringing this into it, is that the relationships and the conversations are not centered around any one researcher or any one charming or dynamic personality. So no one PI can, if that PI is not there, or, if that one person is not there. Second is every researcher has to navigate in this and find their own identity and find their own voice. So the participatory action research, therefore, is the larger journey. And we see these individual research pieces and projects, which come with varying caveats, disclaimers and things like that, into it. What is very important, though, and we recognize it, is harmful questions, harmful methods. So we're also very clear about needing to review opportunities and also reject them, because the investment that we're making, very easily a very large grant from an international organization who's not really interested in the conversation can completely break all that work. So that is, like, again, what was being said, funding models are tough. So we do struggle a bit with that. But again, going back to what one of the speakers said about being in the struggle, living and working with these communities, as health workers, as neighbors, as, like they are my daughter's friends, are also my, are my colleagues, research respondents, and our team members for someone else, So all these boundaries go away over time, and then we respond better. Thank you.
Thank you, Tanya. Thank you, everyone, for your time. And I think just to wrap up, my takeaway from today's session, and what I'd like to do is maybe give you all a couple of minutes after I close, while while I hand it over to Ketki, if there are any Q&As that you would like to respond to that were given to you, please go ahead and respond in the chat box as well. Thank you. It's been such an enlightening session, and I really loved my takeaway as a researcher myself is to really be able to look in the mirror, to be comfortable with being uncomfortable and the struggle, and to be aware, to look at long-term goals, not short-term commitments, to really work collaboratively, and to be a different sort of researcher than what we've been accustomed to being trained into, and that it's a iterative long-term process, and that we'll all get there, and we have to be aware of our inherent barriers in our own journeys as well. So thank you so much. Ketki, I'd like to hand it over back to you, and thank you once again, all of the panelists, for your time.
Thank you, Iman. I would like to first thank all our panelists today for such an insightful talk and for engaging and for bringing out a lot of discussion on how to engage your communities and how to make them equal partners. I would like to also thank Iman for moderating this session and taking forward the questions in this session. Apart from it, I would also thank all our presenters, yesterday's and today's, for sharing their work with us. And finally, I would like to end with thanking all our collaborators, Health System Global, Institute of Public Health Bangalore, Access Health International and Global Learning Collaborative, and Health System Trending Accelerator for supporting this event. Yeah, thank you all, and see you again in the next event. Thanks.
Thank you.
Thank you, everyone. Bye.
Bye.
सडक सुरक्षा समिति गठन गर्ने अनि त्यो चाहिँ हाम्रो कस्तो भने यो फेरि मैले भने